obviously be very informal. Thank you ladies for coming.
Yeah.
We're gonna do sort of all questions answered, talk about dry needling.
Gotcha.
It's something we're very excited to bring to the clinic, and it seems that our patients are either ready to go and have it done, or they've got some questions that they need answers. So we thought we would take some time and put some information together to help everybody make an informed decision about if they want to add this to their treatment. So you guys know me, Jen Neesett, owner of Fit for Life, and then my colleague Raven Anspaugh, and we're just going to kind of tag team back and forth. So please interrupt if you have questions.
All right.
We'll see how this goes. So a little bit of a agenda about what we plan to talk about. We're going to give a little bit of a history about dry needling, where it came from, talk about the benefits, risks, and really precautions. There's only a few contraindications or times when we would not do dry needling. We'll do a little bit of talk about the science, how it works, who it can help, and then we'll have time for questions at the end if we don't answer them throughout, and a demonstration if you guys are interested in seeing a little bit. So I will start by talking a little bit about the history of dry needling. It dates back to about the 1940s, and it is based on parts of traditional Chinese medicine, in particular acupuncture, which is one part of traditional Chinese medicine. So in theory, it comes from that. It also comes from large part of the work done by two doctors, Dr. Travell and Dr. Simons?
I think it's Simons, yeah. Maybe.
Those doctors are the ones who kind of led the way in myofascial release, like describing it, myofascial release syndrome, and myofascial pain, basically, and trigger points. So dry needling is the marriage of kind of those two fields together. It is theoretically based on the body's ability to heal. So we are using a needle to interrupt the tissue, causing some microtrauma, and Raven will talk about this more later, but it is knowing that your body's goal is always to get back to baseline or homeostasis. That is the theory on which it is based. It does cause changes in the biochemical makeup of the tissue. So that is the brief history of dry needling.
Okay, so this so far is probably one of the biggest questions I feel like we've been asked on a consistent basis, and it's always phrased as, is this the same as acupuncture or similar to acupuncture? So we tried our best to break it down so that you can really compare and contrast the two, because like Jen said, they are born of the same principles, but the techniques themselves are different. So you can see they both use needles, obviously, and actually the acupuncture needles and the dry needling needles are the same. So they are not the needles you're used to at like your doctor's office if you're, say, getting a vaccine or a shot. They're just that monofilament, singular, thin, flexible needle. Acupuncture in traditional Chinese medicine, so if you see TCM up there, that's what we're referring to. Acupuncture works off of meridian lines in the body, or your qi in the body. So no matter what you're coming in for when you do acupuncture, they're going to base where they're poking you or where they're putting the needles off of where your diagnosis falls within those meridian lines. And then you could see that acupuncture does, because of that, virtually treat almost any diagnosis. You've probably heard of it used for IBS or other bowel issues, sometimes cardiac problems.
Infertility,
exactly, yep.
Anxiety.
And other things too, like back pain and ankle pain, there's definitely an overlap. But the point selection, again, is based off of where you fall on that map. So then dry needling, it's governed instead of by these meridian lines by the principle that your baseline, so where you are at basically your best, is based in your nervous system. So your brain and your spinal cord, it's a genetic code. Your brain and your spinal cord control it. And so what we do with the dry needling is we do a selection of functional testing, muscle testing, palpation. We're looking at the quality of the muscles. And where we find the dysfunction is where we're placing the needles, or close to it based off of a referral pattern. Okay. So then let's talk a little bit about the benefits, because I feel like that's one of the biggest things people always want to know. And you'll notice probably quickly that a lot of the benefits piggyback off of each other. So, you know, it's not a mutually exclusive thing, just like it's not with a lot of treatment techniques that we do here. You can see the top is pain relief. It could be fairly instantaneous. I'm sure you've probably had some patients get instantaneous relief. I have as well. Sometimes it's within 24 hours, sometimes it's within 4 or 5 sessions. The reason people get the pain relief is because of the release of the tension in the tissues. It is because of the inflammatory response that it induces within the body, and it is because of those changes. And it's because of those changes, so that natural induction of your body's own inflammatory response, the release of tension, that you get faster recovery. Now, the other thing too to note is that when you release tension, when you release, you know, pain and different things like that, you can have improved range of motion. You can also have improved posture. I actually had an individual who could not put their heels flat during a squat. 1 session of dry needling, heels to the floor. So it is very cool to see how even just 1 session of dry needling makes such a significant change. And again, this goes back to that principle, just like MYK, how MYK is rooted in the brain and the spinal cord controlling everything, if you guys have had that.
Is that where you go like this and stuff?
Yes. Yes. It requires a very certain rhythm to do, and I don't know if I lack the coordination, but I try.
Well, it's just, yeah, like,
Tapping the muscles,
Yeah.
brings it back to the
Yeah.
spinal cord.
And that's a lot of triggering different receptors so that they'll communicate to the brain. This is very similar. So a lot of this is rooted in those neurological changes that you're gonna get.
Complementary therapy.
Oh, yeah.
Just how.
Yeah. So oftentimes what you'll see and what we learned even during class is that it can be a standalone treatment, but it can also be heavily used as a complementary therapy. So when you come to us, especially, you're still gonna get the MYK, you're still gonna get Graston, you're still gonna get taping. Reason being is that as a standalone, it's good, it's great. As a complementary therapy with other things, it's fantastic. So we try to pick and choose different MFR techniques or myofascial or MYK that are going to cover the same area so that we can compound the effects that you're gonna get.
Okay, so what do you need to know? What are the risks and what are the contraindications? So what could happen during a dry needling session? The very common risk is local pain or discomfort. And I would say pain is probably a strong word. It is oftentimes mild discomfort. Sometimes people don't actually feel the needle go in, but what they feel is when we get the needle into the tissue that it needs to be in, we do a technique called whirling, where we'll twirl the needle to get the fascial system bound up under there, and that will sometimes cause like a reaction.
Or the muscle twitches.
yeah.
Or a twitch.
Yeah.
It is. I've also had it explained to me that when you are in chronic pain, this additional, insult to your nervous system is insignificant. Yeah. It really, I had an IV this week, and that hurt much more than.
Yeah, that's hard on my hand.
Yeah, yes. So pain or discomfort is very, very minimal and shouldn't be a reason not to try it. In fact, I would also say that any myofascial release that you've had with our hands or our tools hurts more.
I have gotten that same feedback. Most people think the Graston is worse.
Yeah, yes.
I've never had the Graston, I don't think, done, because
I can't call it Graston because I don't have the certification or the tools, but I do scraping. I call it scraping. Yeah. So I do.
And that's kind of what it's like.
Yeah. Yeah, she's just better at it.
She's better.
I gotta give you a
We
try.
all have our thing.
Well, you know what, and I think that part of it is you have to get out of your head. Like if you get in your head about it, if you're like,
Yes.
oh my gosh, like that's gonna come, you're waiting for that. And if you don't, if you just say to yourself, this is gonna be okay, and
Mhm.
try to think of other things.
And we'll talk about that a little bit later when we talk about the, I think it's on the next slide, but that fear is a legitimate thing. The fear of
Mhm.
needles is a legitimate reason we won't do it.
Mhm.
Because if you perceive the treatment as a threat, it's
Mhm.
not likely going to be
Yeah.
helpful.
Yeah.
So local pain or discomfort. The other thing that you can expect is that there should be some muscle soreness. It should feel like you worked out, maybe for 24 to 48 hours. Again, also not uncommon if you've had manual therapy in the past. So occasional discomfort with the placement of the needles once they're in, it's very common for people to say they don't feel it anymore. The needles are left in for a period of time. And every now and then when we take the needle out, there may be a little bit of speck of blood that comes out. It just sort of depends on the tissue that we went through. Some bruising, again, I haven't seen that yet, and it's definitely
It's
something.
probably more vascular places that it starts to bleed or something.
Yeah, and like the things
Some
that
people are just natural bleeders more
we
than
all
more
see it
so
with
than
Graston
others.
too.
Yeah.
So those I would say are common things that could happen. The next three are very rare. In fact, when we were talking about nerve injury before the class, when we were taught this in the beginning of December, our instructor basically said, it's very difficult to hit a nerve. Number one, we take precautions. It's our job to know the anatomy and to have our good palpation skills. We'll show you a little bit later what I mean by that. But if we know where things are, we're going to avoid them. We're going to mark them. And if you accidentally hit a nerve, it would possibly be because the patient has some kind of anatomical
Anomaly.
Yeah,
Yeah.
like the sciatic nerve sometimes,
Yeah.
its placement with regard to the piriformis is different. So, but what he said is, you may hit it, you can't, it will move though. Like the nerve's gonna move out of the way. The patient may go, whoa.
Yeah.
Mhm.
So that's kind of what we wanted to talk about that. It has not happened, for either one of us. Infection, also very rare. That would happen more along the lines of someone who recently had surgery, if we needled around the incision too soon, or into a joint line, which at the current moment, neither one of us are certified to do. So, and
What
then
do you mean by a
also
joint line, like in the knee or something?
Yeah.
Okay.
into the joint space of the knee, into the joint space of the shoulder.
Oh,
Like,
okay.
yeah, inserting the needle into the joint space could introduce, so that is that risk. Pneumothorax is probably, for Raven and I, the scariest one. Oh, hi, Sandy, that's okay. You guys know what a pneumothorax is? You know what that means?
No, I don't know what that
It
means.
basically means we would puncture a lung.
Oh,
And then the
okay.
And-
lung collapses,
and
or a
the-
portion of it collapses.
And it's temporary, right? It's not
It is,
comfortable.
it is.
But the risk of infection is like 0.01 or something, and all of this is evidence-based. The risk of a pneumothorax is like less than 1%, and it's in those muscle groups that are in the field of the lungs. So your upper traps, the muscles on the rotator cuff, your thoracic spine, the middle of your back. And so one of the other things that we are kind of realizing is the way that we're going to keep ourselves safe and you guys safe is we're only going to needle the muscles that we feel comfortable needling right now. So again, it's a very small risk, and as long as you follow the anatomy and palpation, it's.
But how can it really, like, how does it actually happen, especially if you're going up here? Like, I think I understand more
I
here.
think it's probably happened a little more commonly, like in the thoracic spine.
Yeah.
If you're attempting to, or you maybe go through a rib,
Well, that is,
the
so
intercostal space.
there's a couple articles that you can look up about it's called Minimizing Adverse Reactions to Dry Needling, and one of the most common mistakes a practitioner can make is palpating a rib rather than the border of the scapula, because they are both rounded bones and feel almost identical, and so that is the most common error made. And then what happens is if they think the rib is the scapula, your goal with needling is to actually hit the scapula. So I'm sure you can imagine if you have a rib and the ribs are very small, you go through it and
You don't
Yeah.
you're not where you think you
Yeah,
are.
and
the
see, I don't think of
long-term
a rib
weight
up here, I just think of ribs here, but I guess they
Yeah.
do
So
go all the way
the
up
lung,
here.
the lung field, the apex of the lung does come above the collarbone.
Yeah,
Yes.
it's like, I guess it's because you can feel the ribs, but you
Yes.
don't really
Yes.
think of
Yeah.
it up here. But yeah, if you look at a skeleton, yeah, they're all the way up
Yeah,
here.
so the pecs are
Yeah.
a region at risk,
Well dressed.
And like Jen said, we do take the proper precautions. We
Yeah.
are palpating, repalpating, marking it, having each
Checking
other
each
check.
other.
Yeah,
Yeah.
okay.
or just avoiding it for the time being.
Yeah.
So those are the risks. The next slide, we're gonna talk a little bit about kind of precautions and when we wouldn't do dry needling or things that we're gonna take into consideration. As we mentioned earlier, if somebody really is afraid of needles, it's enough of a reason not to do it.
Mhm.
Because as I said, if the patient perceives it as a threat, it's not gonna be they're not gonna be relaxed and it's not gonna be effective. Hyperalgesia and allodynia are two medical words. What they mean is hyperalgesia is like an elevated pain response to a stimulus, and allodynia means something causes pain that shouldn't, right? So think of like
Tickling.
a feather tickling you or something.
Mhm.
They're both conditions of the nervous system that just gets fired up for some people. In those patients, I think we can kind of tell we wouldn't want to introduce a needle to those patients. Abnormal bleeding tendencies is on there. What I kind of mean for that is if you're on blood thinner, we take precautions. It's not a contraindication. We may limit the number of needles. We may limit the depth of the needles. We may avoid certain body parts that if something did happen, we didn't have direct access to, like compression, basically like the hip, the groin. And then immunocompromised would be a precaution. Why? Because, like we mentioned, dry needling by definition is based on your body's ability to heal. So if you are working on something else, if you're immunocompromised, your ability to heal is lessened and it's not going to be as effective or comfortable for you. When we wouldn't use dry needling, basically if the patient is not able to communicate and give informed consent, whether it's a language barrier or a cognitive barrier, the patient has to be able to give you feedback while you're getting the procedure done, but they also need to be able to understand what you're doing and give informed consent. So significant cognitive impairment, we would not do dry needling. It is a contraindication in the first trimester of pregnancy. We do not do dry needling around varicose veins, so vascular disease. Patients currently undergoing chemo and radiation, just as we mentioned, their body is busy dealing with other things at the time. He was not clear on how soon you could do it after they're finished, but sort of judgment call, I guess. You would not do dry needling around any cosmetic surgical implants. For patients who are allergic to metals, though I did read that there are, I think it's gold and silver needles, which
There are some that are
we
gold
don't
and
have
silver.
those.
We love our needles, but not that much.
So that would be a contraindication. You also don't do dry needling over local skin lesions like psoriasis, a breakout of psoriasis. We would not do that. We avoid things like moles and that sort of thing. And then within 3 months of surgery, you do not needle, particularly the scar, for the risk of infection. And up to a year, they really tell us to get permission from the surgeon to do dry needling. Every scar should be needled is what we were taught because of the restriction in the tissues that it just causes. So
But not in the
for
early
the
stage.
first 3 months.
Okay.
Yeah.
You do have to let the full natural closure take place, and then the risk of infection will go down after 3 months.
Okay.
And I want to clarify too, so I know I personally have a lot of patients that have implants as far as like hip replacements, joint replacements. That's not what Jen's talking about. We're talking about like anything that is a saline based implant, right?
Yeah.
A saline based implant.
Yeah.
Okay.
And then we could happily needle your calf, but not your pectoral muscles.
Some people have them in their calves, some people have them in their glutes.
Oh, I guess. Right. Okay. I
They
should-
do?
I should.
Oh, yeah.
In their calves?
Yeah.
Or their bum.
Or
Yeah.
deltoids.
Yeah.
Why would people put them in their calves?
To make
They
it look
want bigger
bigger.
calves.
Yeah.
Yeah.
Because
fine.
they
My calves aren't really pretty looking.
You're
Like
not shaping
Alicia's?
that.
Yeah.
Really? That's ridiculous.
And the deltoids deltoids are a thing
Really?
too. Mhm.
Oh,
So yeah, I can't just do men. We'll need a lot of parts of the body, just not
Exactly,
like
exactly.
8 C-sections?
Yes, so I've had 9 like surgeries out of the same
Oh my
spot.
goodness.
And I've never had that done, and I had it done, period.
Did you? Did
Mhm.
she?
And what happened was, all of this that was holding everything tight, like because of the fascia was so tight, I started having issues with my hips. And then they did it, and now everything's like all loosey goosey, and I'm like, ah,
That was what
But
was
it was-
holding you.
cause that's what was holding, yeah, but that was causing other issues.
Wow.
So, yeah, so
Oh,
they did
that's
that.
interesting.
Yeah.
That's
they
like
finally
even like
did
with
that.
plantar fasciitis, like
Yes.
they cut the fascia to,
Yeah.
well, because I've had both my feet done. Like,
Yeah.
So I've
I
had
guess
that
kinda,
done.
but it's not really.
Yeah,
So would dry needling be something that you could use on plantar fasciitis?
all the time.
I get, right here, she puts 2 needles here, needle right up on the Achilles.
Oh.
That's
Yeah,
actually
and
one
that
of the
helps.
diagnosis, it's.
Are you willing to share the scar? Can you tell them about the
Mine?
scar, the results we're getting with the foot?
Oh yeah. So I had foot surgery because I have hammer toes, and my doctor, who I love her, but she did the surgery, and it got worse because the way my foot is. I'm sorry, my feet are not pretty,
No,
but
that's okay.
I have a really
Not
high
afraid.
arch. Okay.
Uh-huh.
So she cut these 2 toes, cut this one, trimmed the short one, but she pinned these 2. And these, you can tell right here, they're bent. The scar was never, so we just started working on it. Because I have so much tension from that scar, from those 2 scars, that I literally, that bump there on the second toe, which is lovely, it actually, when I get tense, everything goes, and then that thing starts hurting. And so now we've been working on it, and I actually have started feeling, it actually hurts
I
now.
was gonna say, we're getting
Because I can
sensation
feel-
back.
I haven't been able, it was 2014 when I had it done.
Yeah.
I haven't had sensation in my foot. And when she started, she put the needles in, and she's like,
She was like,
does
no.
that hurt? And I was like, nothing, I got nothing.
Literally.
Yeah,
She's
and,
like, no.
and today I had more, like she was
Yeah.
able to put it in there, and I was like, oh, I can feel that. But she went right up the toes, and I was like, I got
Good for
nothing.
you.
Yeah.
So
We're
yeah.
getting,
Wow.
that's like a prime
Yeah.
time scar.
And then she
example.
does mine here, she'll put needles on my Achilles. I know that it sounds a little, but it doesn't feel bad.
That's a technical term.
It doesn't.
Yeah. Well, that's a good segue then into how it works. So I'm gonna tell you guys about how it works, and you're gonna see a lot of how it works is also the benefits, but I'm gonna go a little bit deeper into, the actual science behind it. So try and follow along with me because I'm gonna jump around a little bit, but the biggest thing that I want you to know is right here in the middle. So it disrupts the pain signals to the brain. I want you to think of your neurological pathway, so from your brain to your spinal cord out to your limbs, as like a highway. You have different receptors in your body, they're all like cars. Your highway, when you're in pain, gets clogged with vans that say pain, 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 pain. And your brain starts to forget about all of the other on and off ramps. Things like pressure, things like sharp touch, things like light touch. And what the needle is going to do by the introduction of it, not even the twirling like Jen mentioned, or any other kind of technique that we do with it, simply by placing that needle, you are disrupting the highway. So you're introducing a new car that says sharp touch. Some people do get temperature changes too. But that's the initial part of retraining the brain, so changing that actual cognitive neurological reaction. And then down below it, you'll see myofascial release. So that goes one step further. And that's things like your whirl technique that you've heard us say, or pecking. If you've had this done, you know that when we do go into the bone, we peck at the bone to help release the tendon attachment. Those are all different types of what they call mechanotransduction. That's the fancy physics term for it. And that basically means that you're disrupting the shape of the tissue to trigger 2 things. 1, other receptors besides pain. And 2, you're triggering the brain to say, oh, I need to go fix this. Because there is a difference between acute inflammatory response, so when something first happens, versus a chronic pain or a chronic inflammation. That's that sort of like bad inflammation, if you think about it that way, because it's just stagnant fluid rather than your body giving you fresh blood with the good cells to take out old tissue and bring in new tissue. So then, you know, more specifically how dry needling works versus something like a Graston or a myofascial release is that with dry needling, we are able to be a lot more specific. So we're really able to get down to the source. A lot of times what you'll hear Jen and myself say is that, you know, if we're trying to work out, you know, your piriformis, which is underneath your glutes, it's very hard for us to do. And not just on us, but it's also very hard to get to because it's a deep structure.
What are you gonna put the elbow in there?
Yeah, you can. I'll say like 90% of the time that works, but there's like 10% where, say somebody has tight glutes and you're just working through layer after layer of tension, you're not actually getting to where you need to be. So with dry needling, you are getting down to that tissue and it's more specific. So then you have a couple of other things, how it works as far as, you know, promotion of healing. It's that acute inflammatory response, like we mentioned, where it's gonna promote the brain to send blood flow to the area. And then that's where you're going to get, you know, a reduction of muscle tension, both from the actual technique itself and from the increased blood flow. But then you're also gonna get an added benefit of pain relief because it releases endorphins. So your serotonin, your oxytocin, all your happy hormones that everybody wants. And that's, I think, why a lot of our patients say it feels like they worked out, because they get that release of hormones and endorphins, and then you almost come back down. And it's common, we'll talk a little bit more about it at the end, to actually feel tired after dry needling because it triggers a different type of response. So then who can this help? This is not an all-encompassing list, okay? These are probably the most common things I think that we treat or have used or seen in association to choosing dry needling as a technique. So, you know, most of our patients fall in the category of some kind of neck pain, back pain, sciatica. I also treat a lot of patients that have plantar fasciitis or carpal tunnel, tennis elbow. You'll see shoulder pain on there as well. But it is also, you know, for conditions like fibromyalgia. So, you know, chronic pain is not a criteria to not have dry needling. I feel like a lot of my patients have thought that this is something new for new injuries, but it actually does help with chronic pain as well. It just may take a little bit longer. So you'll see fibromyalgia up there, TMJ disorders. What we do with that is we don't actually dry needle into the jaw, we dry needle around the head and the neck to help release some of those muscles. That also goes along with your headaches and your migraines. Sports injuries, depending on what category that sport injury falls into, we can dry needle for those to get kids back or get adults back to whatever they want to do quicker. And then we've obviously already talked about scar tissue, so that's your scar treatments. Interestingly enough, one of the things that we learned was that one of the most researched diagnoses with dry needling benefits was actually knee arthritis. And they found that dry needling, I think it was like something upwards of like 70% of the time, can improve pain with arthritis. So I thought that was pretty cool.
Okay. We're going to show you some pictures. We want to show you some pictures of what it actually looks like, and we'll sort of talk through a little bit about like what a session would look like and how we prepare ourselves and what we're actually doing when we do that. So the following two slides have pictures of, it's us largely and people that were on the course with us. This is just one example for those of you that have not seen what the needles look like. This is just one particular size. So they come in packs of 5. The size depends on, there's many different sizes, there's many different thicknesses, and we make a decision on this based on what we're needling. So we would use a different size needle for different muscles. They are sterile, they are self-contained, and it's just a thin filiform
Monofilament. Yep.
Needle is contained within each tube. So that's what that looks like. So here you're going to see some of the things we did while we were on the course. Not super great images at the moment, but so here, this is the typical treatment for a calf. We would use it for Achilles tendonitis, plantar fasciitis, calf strain. There are 2 needles here. It's actually this size of a needle. Those are in his gastroc, the upper calf. You would, in a typical treatment, probably see about 2 more, so 4 needles maybe, depending on palpation, right, of the muscle. We're gonna put it where it's restricted. There's 2 needles here that are purple, so they're a little smaller. And those needles are going into the junction where the gastroc meets the soleus. So we can put a needle into a muscle, the gastroc. We can put a needle into the muscle tendon junction, which you see here. We can put a needle into the tendon directly. So there's 2 needles directly into his tendon. And then there's 3 or 4 little yellow ones that go right into where the tendon attaches to the bone. And it's a teeny little needle, it's not in there very far, but the beautiful thing about that is, the magic of that is when we can get to the bone, we do something called pecking. So we will peck the bone, which is a microtrauma, which is gonna bring blood flow. And tendons don't have good blood flow. So it's gonna initiate that healing response that we've talked about and sort of bring good blood flow to that area. This is a picture of teres minor. Teres minor is a rotator cuff muscle, so it's located on the back side of, this is Raven's shoulder blade. What we wanted to show you, so in full disclosure, this is a muscle that we haven't quite felt comfortable needling here because of its relationship and closeness to the lung. It's also a little one that's yellow, right?
Mm-hmm.
It's a little needle, so it's not going in very far. You notice the redness that you see on her shoulder blade there? She had previously been needled in some of the other rotator cuff muscles, so that is a vasomotor reaction.
Yeah.
That is a desired response. It is her body's reaction. It shows us the necessity of it, the restricted tissue, and her body is reacting by bringing blood flow to the area, and that is a very common reaction. So that is her teres minor.
So because it's restricted, and because you put those needles in there, that's why you're seeing the red, because of the blood coming
Yeah.
in there.
Yes, to try to heal itself, yeah, and initiate that.
And you must be really tight in
I
through
know.
there.
I warned them,
She
I warned them.
was, yeah. So the middle picture is a demonstration of the needling of the pec major and pec minor. We took her face off. I think her head is actually, oh, it's right here.
That's her nose
Yeah.
right there,
So
yeah.
she's got 2 needles going that way, and you see the important thing would be that the placement of the needles goes away. They go this way and not this way towards the lung field, and then pec minor there.
And they're also angled very flat to the skin.
Like
So
tangentially.
the more parallel to the skin you are, obviously the less depth you
Yeah.
get.
The 4th one is the piriformis. So I would say for me, the piriformis and along with the cap, so this is one of our favorite ones to do, very safe. The piriformis and the glute med and glute minimus, so the butt muscles, they're like the safest things to needle, basically. There's very little neurovasculature. Neurovasculature means the blood vessels and nerves that we're watching for that we have to be careful for.
I also love those ones, sorry not to.
That's fine.
I also love those ones because they get us, I feel like, the quickest response.
Yeah.
I have seen the best responses
Yeah.
to needling the glute muscles in the piriformis.
Because it doesn't have stuff going through, or because it does?
No,
Did
because
you
it's
say?
usually so restricted that even one session patients feel a difference.
Oh, but what were you saying about the blood
It's
vessels?
a safe,
Oh,
so it's a
Oh,
safe
yeah.
area to
Mhm.
needle.
Yeah.
So
okay.
one of the ways we keep you guys safe is we need to know our anatomy and we have to be good with our palpation, right? And we have to be aware of the blood vessels and nerves that are in the area that we could hit and how to avoid them. So the way we do that, especially as we're learning, is by marking. So if you're gonna have dry needling with us, most likely we're gonna have a little marker and we are gonna be marking out the things we need to know. So for the piriformis, what you'll see is she's got this little,
Right there.
that's the glute med.
Well, that's from, it's left
Oh,
over from.
is it?
Yeah.
Oh, she know what? I think she.
It's left over.
Person. Oh, that is.
We're backwards here.
We are backwards.
This is glute med, so here's glute
She
med,
has a label wrong.
glute min, and TFL, and this is piriformis. But you can see, like, if you do multiple muscle groups, we're gonna mark it all, so you're gonna end up
Yeah,
with
that's right.
some
She doesn't mention
residual.
So you see the no over on the far one, that's the location of the sciatic nerve, so it's sort of telling us we're, don't go there. But that person has 4 needles through their piriformis and then 1 needle right in the side going into the greater trochanter. And then the other one was the titles were just flipped.
Yeah.
That's what I need.
Yeah, more Raven. So this is what a needling looks like for the cervical spine. Actually, this is also one of my favorite techniques because in my brain, everything does come back to the brain and spinal cord. So if I'm not comfortable needling the muscles of the rotator cuff, I know I can still impact them by going to where they start, which is the level of the spine, so similar to MYK. And we were actually taught that an effective treatment, you treat whatever the issue is, you treat along the entire myotome basically. So you take it back to the level of the spine. So with the neck in particular, well, the neck, the thoracic spine, and the lumbar spine, we're taught safely how to do it. It's all muscles. It's all muscles. So for the neck, everything's in the front in terms of blood vessels, and the spinal cord is very much protected by the bones themselves. So
doing that back here, would that affect with tightness here? Because you can't you're not gonna be able to.
we can't,
Yeah.
but you can needle the muscles in the front. That's dry needling too.
Oh.
And I will say, to answer your question as well, yes, I do think that would help, but also this technique up here where it's labeled as headaches,
Yeah.
that's actually a suboccipital release technique.
Right.
So a lot of you have probably had that where Jen and I actually pull it with our hands.
Yeah.
And
A
hold it.
lot of the muscles in the front do attach either on the side or on the back of your skull. So
Yeah.
that right there is a huge one to affect those front muscles.
Yeah.
And again, very safe
Mhm.
when it's done correctly. And then the bottom one just shows you a sample needling for some of the muscles of the low back.
Well, you know what? One of the things that I love about you guys is that you are very transparent. Like, we're gonna do this. We're gonna try this. Hey, this is not looking like what I want. I'm not comfortable. They won't do it. Do you know what I'm saying? Like, other people may be like, I'll just do this, or hey, what the heck? Who cares?
It looks like you're
They
being a
will.
guinea pig.
Yeah. Oh no, they will not. They will tell you, hey, this is what our goal is.
Yeah.
This is what we're gonna try. I'm not getting a good response. We're not gonna try it. And
that
that's
was
the
one
best
of the
thing.
things they said in
Yeah.
class, our instructor
Don't
literally
bury-
was like,
don't
don't bury
bury
the
the
needle
needle
and
and
then figure out
Yeah.
there's a problem.
Yeah.
Stop well ahead of time if it doesn't feel right.
Like how far, I mean, I know you guys use different kinds of needles for the depth and everything.
So
Like how far really do you get down to really think you're gonna puncture an artery?
well, so it does.
You know? Like, I know you gotta provide the risk
Yeah,
and
yeah.
stuff, but really.
So in that same, it's a fair
Ball
question.
blood.
It's
Yeah,
a fair
yeah,
question.
absolutely. Yeah.
I will tell you guys, my husband is an ER provider, and he also verified that the risks are extremely minimal
Yeah.
and not as
Yeah.
concerning as they would have you.
Yeah.
But that same,
You have to put it
overstress.
out there
You do.
so that,
you do.
but I do understand, if you wouldn't be doing it
Yeah,
if it
wasn't
was.
safe.
Exactly.
Yeah, there's a risk to everything, so.
So,
Yeah.
Yeah.
what I'm going to show you, which is very hard to see, this is a 50 millimeter if you only are looking at the needle. So handle does not count.
Yeah.
So this is a 50 millimeter.
Uh-huh.
They have done enough research to show that this is the average width of a thoracic. Actually, I think it is 50, or is it 40? It's either this or it's slightly smaller. So it's either 40 millimeters or 50. This is the average width of a thoracic vertebrae. Where you would run into concern is that obviously once you get to the end of the vertebrae, then you have a rib. What we're taught, so you might be able to see it a little bit better. So you can see my 3-finger width is not even going to come to the end of the needle, but you will enter the needle at the middle of this finger and this finger.
For the thoracic spine.
For the thoracic
In the middle of
spine.
your back.
So you're taking that whole width and you are cutting it right in half, so that your chances of even hitting a rib are very
So
slim to
essentially,
none.
it's like if you just look at the needle
So it's
part,
only
not the
gonna go
handle.
in
Right, and I
maybe an
think
inch.
You
Yeah,
said
it's not even like, it's like probably like half the needle.
Well, yeah,
Not
because
all
you
the
also
that,
angle it.
depth wise,
Right.
is the lung field is what?
It's
Greater than 20?
on average, so a average BMI person, it is 25 millimeters from skin to lung.
So
Okay.
half of that needle if we went straight down.
Well, I got a huge BMI index, so you won't get anywhere.
It does, well, the thing is though, is that same article, you know, it does talk about you are gonna have patients who do have a very small BMI, and I'm talking BMIs less than 19, and that is a consideration. I mean, I'm what I would
I really
consider an average BMI, and you can see
Yeah.
on me here, so this is my thoracic spine, and I'm breathing, I'm standing, I'm here. That is
Okay.
buried to the handle.
Yeah.
So
Yeah.
that is,
Okay.
And the
That's
teacher
this
did it, so
guy.
you know it's good.
that's this guy.
Yeah,
All
So
the
it's
way.
buried almost to the handle.
Yeah,
it's going slightly.
and it's going at an angle.
Well, and then your body tells them, like, your body's reaction,
Yeah.
they're in tune to that, they're watching.
Yeah.
They're not just throwing it in there, they're actually
Yeah.
watching everything. And for me, we tried the thoracic
Yeah.
spine, and my body was like, nope.
Kicked it right
It
out.
kicked it right out, and so I just told her, I said, we'll just wait. And
Oh,
she
because
said,
it didn't like it? Like,
Yeah, it's
Too
not
much
ready, I'm
restriction.
too tense.
I had that on
Oh.
somebody's upper cervical spine. I'm like, that is not going in.
Yeah,
It's
to
just-
literally
yeah.
too much
Really?
restriction.
Wow.
Yeah.
Yeah, it'll kick it out, so, and they're watching that.
This is a sharps container.
So that's sort of what it looks like. I think that's.
Yeah, I just don't wanna sit here and keep talking with the needle, cause I'm
Choke
hoping that
yourself.
conversation it'll be in my thigh. So a few things to note, these are all things that we would tell you, you know, if you were going to have dry needling done, is that we do want that acute inflammatory response. So the first way to ensure you don't get the result you want is to go home and immediately ice it and take ibuprofen and NSAIDs. So you'll hear us say that you should avoid those things for about 24 to 48 hours. Same thing with heavy exercise. The reason actually that we don't want you to do heavy exercise is because of the reaction I started to mention earlier, which is a parasympathetic response. So it's not uncommon for our patients to tell us, oh, I already feel like I worked out, I feel tired. We ourselves, I could have slept probably for 5 days after a class because it triggers your parasympathetics, which is your rest and digest response. So when you get a good dry needling session, your body does not want to do those things, and to force it past that response is almost going to negate the effects of dry needling. So then, like we said, you may feel some soreness, you know, like you worked out. I think the most common response I've gotten has been patients say they get a little cramp or cramping in the muscle, and you may feel fatigued as well.
I think it took us Wednesday of the week we had the course.
Oh, gosh,
before
yeah.
we were like, so I was like, oh, good God, you're back. Like,
Yeah.
we were just.
Brain like in a fog.
Yeah. 3
Well,
days
and
afterwards.
two, for me, because I do have chronic pain, when I get that and I have some relief from it, I just wanna sleep,
Yeah.
because I'm like, oh, thank God it
Sweet
doesn't,
relief.
yeah,
Yeah.
yeah.
Yeah. So we just kind of summarized it for you guys here. You know, it's very safe, it's very effective. We can treat a variety of musculoskeletal conditions, you know, some of the ones that we've talked about, even more that we haven't talked about. And it is a great technique to release tension, improve circulation, and ultimately, you know, promote faster healing and get you out of pain quicker.
So when you go into the spine area, you know, you do, obviously it's nowhere near the spinal, like, cord or anything like that, it's just more on the
You're in
outside.
the muscles
Correct.
on the outside.
So it's nowhere in the. little
So
things in-
part of the learning
little
is
things.
that they teach you in every area what directions you can go and what directions you cannot go in. So, you know, on Herman here, you can take a needle and you can put it inferior, so gliding down, and medial. What you don't want to do is go straight through. So like Jen and I would feel, you know,
This is where the angle of the needles are going here.
Yeah.
Your spinal cord is running straight down the center, so it's in
Yeah.
the middle, protected by the
So you
bone.
go towards the spine, like
You go
this.
this
right
way,
here.
here.
This is
Yeah.
the goal. And you would never, like, we would never feel the spinous process. You
Uh-huh.
cannot go straight in. That's
Right.
spinal cord.
Right.
But so you're taught what angles and
Uh-huh.
ways and directions that you can and
And
cannot
this is
place
all
the
muscles,
needles.
like the red is the vasculature in the front, it's all in the front.
Yeah.
So in the back, you're just
Mhm.
going through tissue, you're just going through muscles.
So you just go, but you go in with the spinal, you don't go like out, like you said in the other areas you were going outward.
So in a lung field, in an organ, you're always gonna go away from it. So whether it's kidneys, whether it's lung, you're gonna go out. And if it's the spine, you're going
Going this way.
toward the bone.
This way, this way.
Oh,
this way.
okay.
And then if we're needling the pec, we're needling this way.
Because your lungs
Okay.
sit right in the middle.
Okay, because like when I think thoracic, I think all throughout, like. So I was wondering if the needles went that way.
Let me
because-
see if I can.
I don't know.
You mean in the back, lower
Yeah, like
back?
your thoracic spine, it's like
Yeah.
all,
Oh,
right? Like your,
well, we're gonna needle close to the spine.
but
for
you
the
don't go
thoracic
outwards because the lungs are right there in
No,
the
we're
thoracic
gonna go-
area.
Nope, we're still gonna go in the middle of the back.
But you, in the front, you go outwards.
Yes.
Yes,
I see.
yeah.
Yeah.
But then as we get lower, so like the one picture was the back muscles,
Mhm.
so these guys are down here.
Yeah,
Then our needles are going out and away this way
Because of the kidney.
to be away from the kidney. And we're
Oh,
below, the
really?
lungs are up here, so we're away from the lung field down here. So
cause
we
the
gotta make
kidneys
sure we
more,
don't.
more in by the spine, I guess, cause I always thought the kidneys, I just, you always thought the kidneys here.
It's right, it's tucked, so you actually have, it's called the costovertebral angle. This angulation right here
That's
ends,
kinda where the kidney is?
ends your lung and your kidney sits right
Oh, I see, okay.
Yep.
I guess it's referred pain then, you feel
It
it
is,
here.
yes,
Okay.
exactly. Well, that's actually a perfect point to make, is that
Mm-hmm.
referred pain, sometimes when we do dry needle, we're not needling, you know, you might come in and you might say, hey, I think I have sciatic pain, I could needle your piriformis, it does nothing, but maybe it's referred pain from your back,
Yeah.
maybe it's referred pain from your
Yeah.
glute.
Well, I was just thinking because of kidney stones, you know, people are always like,
Yeah.
so you think your kidney's like right there, but
No.
really it's not.
All referred pain.
Oh,
What
boy.
other questions do you have? In a study in 2004, out of 760,000 people that had it, there was one exacerbation of depression, one acute hypertensive crisis, one vasovagal reaction, one asthma attack with angina and hypertension. And then the pneumothorax, there were 2. So again,
And there are some times where it could stir up, like you said, you know, what we were taught is that there are a small group of
Mhm.
non-responders, or what they call non-responders,
Yeah.
where it may stir things up, or it may just do nothing, you know, and not help. I've only had that happen with one person, and it was actually in our class, and it was just because the pain was worse. It kind of like that hyperalgesia that Jen was talking about. The pain was worse, and so he
And the
locked
benefit.
his body up.
Yeah, then the
And-
benefit.
And so
During your
we-
training session that happened?
Mhm.
Wow.
And
what
so
are we talking about?
the lumbar spine and the piriformis on Josh.
Oh, when we,
When it literally like locked up, and we'll be able to see that right away and stop immediately.
So you actually see a response from the muscle when you stick the needle in.
Yeah.
Mhm.
And so, I mean, it's a fairly immediate response. What does it feel like?
Do you guys want to see a demonstration?
that's what we were planning.
You want to see me stick Jen with some needles? But yeah, and she can tell you live time what it feels like. I will say it feels different for everybody. I've had things from a little pinch, cramping, twitching. Twitching, I will say, has notoriously been the least favored by my patients. You know, when you get into a muscle that's so heavily restricted and you are introducing that needle, a lot of times that muscle does respond immediately, and it responds by twitching.
Yeah.
That twitching can be uncomfortable. I
It's
won't
just
lie to you.
weird.
And it is weird. It's
Yeah,
a
that's
weird
what happens.
sensation, kind of like
Yeah.
eyelid fluttering
Yeah,
or
yeah,
something
yeah,
like
yeah,
that.
yeah.
But it usually subsides
Yeah,
it
very
does.
quickly. I had one person today tell me that I felt hot. Like I
Yeah.
said, you know.
I get warm.
Yeah.
When you start, the minute you start,
Mhm.
I feel it flush up, like my face gets really warm. But I enjoy, like I've had acupuncture and I've also had dry needling for over a year now. And, you know, it's been, I find it gives me more relief than you know, and in conjunction with the other stuff,
Yeah.
it really helps out a lot. Yeah.
Usually, what I will say too is usually most effects, like if you do get a cramping or you do get some kind of discomfort in the area, it subsides well before we even finish the treatment time. So it's usually pretty
Yeah,
instantaneous.
like does the warmness go away? Because like,
Yeah.
because
Oh, yeah.
that's my thing. When I do have an episode,
Mhm.
I get super warm,
Mhm.
like, you know, like I'm having the massive hot flash.
That's not everybody. I've had that happen one time, once or twice.
What, where you get really warm?
Yeah, and so we also, like, if we know that about you, I will take precautions. Like, if I know somebody is nervous, I'll have Jen come in.
Yeah.
We can distract the skin, so we do a technique like this, and that helps to reduce the sensation of the needle. I have a fan, Jen has a fan, you know, we play
She's classy.
music.
So, the first time we do needling on anybody, they're laying down, just to make sure they're not gonna feel a little woozy or whatever. I'm gonna stay sitting because it's easy for,
I know she won't pass out on me.
I'm not gonna-
Most everybody starts laying down though, regardless of what we're doing. But I know she can handle it. So this is a good example. This is a
Don't say that. Those are like the worst, like, famous last words, and then she like falls over.
So,
Well, you all are witness that she said she could do it sitting up. So
I did.
the deltoid is a very good example area because even though a lot of people like it's not in a lung field, it's not by the kidney, you know, it does have a nerve that cuts through the back. And if you get that, you're just not going to be good friends. And that's just how that's going to go. So what if you get your deltoid down, what it'll look like is we'll have you actually laying down, but for the sake of now, we're going to have her sit and we're going to feel for your bone. Okay, so like I'm going to mark, here's where the front starts. And this is, I'm going to go through this like I would with any of you. Here's where the back is. And then I'm gonna have you push out. And what I'm looking for is that this, so what I perceived was the back of her deltoid, was probably more the back of her humerus. That looks about right. And here's where her deltoid ends. And then go ahead and relax.
you come home with some artwork.
Exactly.
Yep.
Exactly. So what I'm marking now is the front and the back of the bone. And then go ahead, push out for me one more time.
She does a lot of drawing.
I do a lot of drawing, yes. And so you can see, like, I rechecked multiple times because the thing is that people move. I ask you not to, but people still move. Once I get these needles in, please don't move your arm. It's not going to feel great if you did. The big thing is once your needles are in, you do not want to move because if you contract around that needle, it's going to hurt. That's the only time that I have found that anybody's had any kind of pain response to this. You'll also note, so the reason I marked down here, Jen's little tabletop here, is because this is the tendon for the deltoid. So we will actually go into the bone, right through here, and peck at this bone. Anybody who does dry needling for you should never do this portion before they do the muscle, because what happens is if we do this and then I do Jen's muscle and it twitches, also not gonna feel good. Okay, so you'll
have a needle in the tendon.
yeah. It's just and it's not controllable. We have zero control over if you twitch or not. Are you having any pain in the shoulder? Okay. Can I facilitate some? Let's see how
Oh, you'll find some for sure.
that's tight.
Yeah.
If you hear us describe things as appley or banana-ish, those are really technical terms. So usually we just introduce guide tube, guide tube, guide tube. Little poke. No faces.
Like a little burning sensation.
And then you'll see we grab. That's another safety measure. And that's tight.
Grab the muscle.
Right.
And you just,
That's the twist.
She twisted it, and that's kind of the reaction. Like, oh, okay.
And you
And
can
then it's
see, some of it's probably from my palpation, But on Jen, you can see it's already turning pink. So,
Cause she's pink anyways, and so then it starts to show.
so that's that immediate reaction. So usually what we do with the deltoid is one in the front, one kind of on the side.
Do you feel warm or anything?
We picked this because it's a notoriously comfortable area.
I mean, does it even feel like there's a needle in you right now?
Yeah. Same thing.
I just see them to be so small, it's like,
That one didn't hurt at all.
And that one's less restricted. So here we have the twist.
So the more restricted the muscle, the more you'll
I think
feel.
so, yeah.
Mm-hmm.
oh, then I'll really feel it. No.
There are some areas, like, there were definitely some areas I feel like on you, on our other part, on me, that they're just worse. Like, and it's different for everybody, you know?
So like my forearms are super tight. Is that an area you could dry needle or not because there's too much?
No, that lateral epicondylitis
Yeah.
is an area that I've needled
Okay.
multiple times and I'm getting good results with it.
Okay.
So
I guess what we'll probably do next time.
So like right here, your arms are tight.
No, like this muscle. It's actually better because I just had a treatment not that long. But these muscles right here,
There you go.
from
You are
my wrist to my elbow, like these muscles are super
Is it because
tight.
you get carpal tunnel or
And then you
It's
something?
not carpal
That's your
tunnel.
base.
Oh,
It's just
they're just
Yeah.
tight.
Mhm.
That's
Do you
it.
type a lot?
No, but I work in food service.
It's a great team.
Oh,
and I
okay.
cook at
exercise,
home
you know?
and
Spend
Okay.
an entire
Yeah.
weekend
I
poking
was
each
all
other.
ready to throw myself on that table, like,
Let's go ahead.
yeah.
Do it. It's so interesting where everybody
So then
hurts,
how
you know,
long
like.
Yeah.
do you leave the
So-
needles in?
About 10 to 15 minutes usually.
That was
first
my other
time-
question.
the
Like
first
treatment
time we would
is-
do it. Yeah, so what we've just been including it in the regular treatment session for patients. So I may do the MYK on you first,
Mhm.
and then we would lay down and I put the needles in and the first time we did it, they'd sit for 10 minutes. And then when they come out, I would do a little bit of myofascial release or scraping to finish the treatment on that area.
And she is getting that erythema reaction. If you can't see it from there, definitely take a look at it.
Oh yeah.
You definitely
yeah,
are.
her little pink smudges on
Yeah, I
there.
see it.
So that's what I think what we would do. You are can work on your neck while the needles are in. That's something else we've been doing is put the needles in one body part and work on another body part.
That's what Raven does for me. She puts on my foot and then she works on my neck.
You can maybe hit stop on the
Mhm.
right recording one.
Yeah. She wants me to do that just in
You
case.
gotta cut out all my jokes.